So I'm going to turn it over to Danielle now, who'll tell you about her experience with islet transplantation, and Tim's going to do a brief introduction.
Yeah, she can write that. Yeah, so we thought it would be nice for everyone to actually get your perspective from the patient who's received an islet transplant. And Danielle, living here in Vancouver, has graciously agreed to come and spend a few minutes talking about what it was like for her, maybe pre-transplant and post-transplant. So Danielle, thank you very much for agreeing to participate.
Absolutely, anything for the Edmonton Protocol. Thank you so much for this special invitation and to share with you how the Edmonton Protocol and my islet transplants changed my life and how I manage my type 1 diabetes without insulin. So my story began when I was 12 years old. I was already competing at a national level as a springboard and platform diver. So I basically grew up in a bathing suit in the pool. And one Easter holiday break, we were doing this intense training camp. So diving for 5 hours, lunch break, more training all afternoon, dead tired at the end of the day. And that long weekend, I started out of the blue, no signs, having all those classic symptoms of diabetes. Running to the washroom to avoid, starving. Yes, my mom was a nurse, and so a quick urine dipstick and off to the Children's Hospital, and my life had changed forever. I was diagnosed as type 1 diabetic. However, already well versed in strict regimes, self-discipline, and dieting, because of my affinity to the sport of diving and exercise, my parents and the medical team thought that I had a good head start to managing this diabetes that was ahead of me, but boy was I in for a ride. My journey with diabetes started with many different types of treatment plans. I started using pork insulin, synthetic insulins, multi-injections, sliding scales, you name it, discrete pens when they came out, constantly challenged trying to balance diet, this sport that I loved and all the rigorous exercise that went with it. I fed lows, I chased highs, trying to figure out what raised my blood sugars, what lowered my blood sugars. Stress raised my blood sugars, anxiety lowered it. From one day to the next, nothing looked the same. I couldn't rely on things that I had done yesterday to help me with tomorrow. Blood sugars were all over the place. And I even tried using that continuous blood glucose monitoring, often to try and get a sense of what my blood sugar was doing 24/7. I was trying to find stability, trying to minimize and prevent having my diving teammates have to administer the glucagon regularly when I was traveling at diving meets, and trying to prevent myself from wandering aimlessly in grocery aisles, digging into candy bins to try and raise the blood sugars that dropped out of nowhere. So after high school, I chose to slow things down. The struggle between university and diving and diabetes was a bit much. So I stopped the intense diving and I focused just on university. And for many years, I think I managed, but I never mastered my diabetes. But I'm not sure diabetes is actually a disease that anyone can master, per se. So I finished my nursing degree. I certified in palliative and hospice care. I worked shift work. And I decided to invest in that insulin pump Dr. Shapiro was explaining. And I worked with the insulin pump for a good 7 years until I eventually realized that that insulin pump is only as good as its user. And I struggled trying to figure out insulin sensitivities and carbohydrate ratios, and they had this one technique that the pump was known for. It was called the bolus wizard. So I remember trying to eat a piece of pizza and using the bolus wizard, and I thought, I am no wizard. And it wasn't surprising then that my hemoglobin A1C was close to 9.6 and not improving. So what I was doing, as Dr. Shapiro was explaining, I was trying to prevent those dangerous lows and ran myself high. So it was in 2011 when my GP recommended that I consider looking into this Edmonton protocol. And in the GP's office, I remember talking about some of the criteria to be eligible, the support person that you need by your side through the journey, and the conversation about children came up. And it was so happened that the year before I was married, and so I had my support person through this journey. Otherwise, I don't think it would have happened. And the discussion about children was an interesting one because early on in my diabetes, I knew that I just couldn't jeopardize more of my health in order to have a child. So that was partially decided in my 20s. I struggled so that another burden on my kidneys or my eyesight, I just wouldn't risk it. So that was an easy decision, already decided. So I submitted my application, as well as I completed all the tests that were required of me, and Edmonton accepted and had me come visit them for an interview. That's what I felt it was. It was good. I passed all the assessments, and that was early April 2012, and I was waitlisted. So I flew back home to Vancouver here, packed a bag, and I waited for the call to fly back to Edmonton when those islets were ready for me. So the call came Sunday, May 13th, and I flew out to Edmonton to receive my first transplant. While I waited for my new islets to begin their work on their own, the team there helped me wean down off of my insulin. The insulin pump came off, and I began using just a few units of Lantus twice a day, with blood sugars already ranging between 4 and 12. Very excited. I remained in Edmonton for a good month to be monitored by the team, going through daily blood work and medication management, fine-tuning the meds. When I was cleared to return home, I was also at that same time waitlisted for my second transplant. And that second call for the second transplant came June 28th. So only 2 weeks later, I returned to Edmonton. 10 days after my second transplant, I was insulin-free. I returned home within a couple weeks, and with over 1 million islets living in my liver. And my hemoglobin A1C was 5, and it's remained there for the past 6 years. So some of the benefits that I noticed quite soon after the first transplant included the celiac disease. The blood work that I had done previously as a diabetic showed that the transglutaminase IgA level of 50 had come down to 8. And I started enjoying the foods that previously and naturally I had stayed away from. So I grew up with vegetables and rice. As a diver in a bathing suit, that also helped. But the pastas and the breads made me nauseous, so I just stayed away from them. But it just so happened that I married into an Italian family, so that was not an option to not say yes to pasta. So that's come back naturally, that I'm enjoying my pasta. What I also noticed was the peripheral neuropathy. So the tingling and the pain in the legs and the feet went away. It's gone. And my hair and my nail growth started to grow stronger and healthier. So that I noticed right away too. Another benefit I noticed after my first transplant was the weight loss. As my new islets began working, it had felt literally like a flick of the switch. And all at once, I wasn't thinking about food. I wasn't craving food. I didn't need to carry as much food around with me wherever I went. I wasn't starving my body, and my body wasn't starving me. And I literally lost nearly 20 pounds. One of the side effects, I admit, that I continue to manage since my transplant is the proliferative growth of the small blood vessels at the back of my eyes. So the laser treatment and the injection therapy keep those small blood vessels on the retina from growing and leaking. It's like, the analogy I was told was it's like a fresh new garden of flowers that have now sun and fresh water, and before it was a shriveled up garden with no life. So I'm managing those blood vessels at the back of my eye. So here I am, 6 years later, and as excited as ever to be insulin-free. The team there in Edmonton feel like family after all we've been through and how close and supportive we've become together through this exciting adventure. After using insulin for 25 years, I truly believe that my decision to have those transplants and to begin a lifelong medication regime with anti-rejection and immunosuppressants has absolutely restored a quality of life that I had all but forgotten while I was trying to manage my type 1 diabetes. When I came back from Edmonton, that psychological burden of guilt and shame and pressure and worry about blood sugars was gone. And I know that I have that psychological well-being back. And I feel it's directly related to the fact that I don't need to worry and perceive good control. I have good control with my type 1 diabetes. Those new donor islets are taking care of that good control. And I feel that the islets give me the freedom to participate in healthy choices that I can make in my day-to-day life. Whereas before, they were totally irrelevant. Those were the cherries on top of the ice cream I didn't really worry about. But today, I can exercise. I can eat healthy. I drink lots of water. I don't smoke. I ensure that I get a good night's sleep. I take my daily vitamins, and I wash my hands just like anyone who doesn't live with type 1 diabetes to stay healthy. And that's very empowering. So I'm so grateful to Dr. Shapiro and the team there in Edmonton for my new lease on life, and I'm very grateful for being able to talk and present my story. Thank you.
Story, and Danielle's going to be here obviously for the rest of the evening, and I think I was going to offer the opportunity for questions, but I think we'll have Danielle and James at the end for questions, so we'll turn it over to James. So that's where we are now. Wonderful to hear that story, and now James is going to finish with the future with self-transplants for diabetes and in the future. James.
Okay. Thank you, Danielle. That was a wonderful insight into what islet transplantation and what the future stem cell therapies will do. And this makes the point that islet transplantation today is not suitable for everybody. There are not enough organs to go around. And if we do the math, and it's a long math, and you don't have to look at all of the additions here, but just come down to the bottom line here, if we take all the pancreases that are available from every single organ donor in the world, and there were 27,000 last year across the world, that there will only be enough islet cells to treat 0.0009% of the patients that have type 1 and potentially type 2 diabetes in the world. In other words, it would take 9,000 years to transplant them all if we used all the available organs that are available every year. So islet cell transplantation we have to think of now as an experiment. It's not really an effective treatment for everybody with diabetes if we take this forward to the future. But it's been a very important experiment. We've learned a lot from it, and Danielle's told us exactly what a successful cell transplant can do, what it can deliver. And stem cells, I just want to end on the hype and the hope and what is really possible with stem cells. And today there are clinical trials, and we're going to talk briefly about that are using embryonic stem cell derived cells. And the future hope is that we can take patients' own cells or inducible pluripotential stem cells, iPS cells, to treat our cells with cells that are completely compatible with the body. And there are multiple trials going forward in the clinic presently. And this makes the point that the cells that we're testing now in patients are derived from an embryonic stem cell, but only one discarded embryo from an IVF clinic has been used to generate so many cells that we could treat everybody potentially in the world that has type 1 and type 2 diabetes, just from one single blastocyst. So you don't need to think about the embryonic stem cell as being as an ethical barrier. We're not killing multiple embryos in order to provide these kind of cells. And I'm just going to skip along this a little bit. So there are various kinds of devices that we can put under the skin to plant these cells in, and some of them are called immunoisolating, meaning that they are protected from the immune system, and some are not. And then most recently the transplants that we've been carrying out have been originally in devices that were protected from the immune system but now have holes in them to allow new blood vessels to form, which means that they are no longer immunoisolated. So this is the very first patient we did in Edmonton with these larger devices and the small, what are called sentinel devices, where we put them on the abdominal wall and in the skin of the forearm and arm. And we've been taking these little devices out at different time points to learn how the cells are surviving. And it's been a very simple surgical technique, but the patients have been phenomenal. They understand when they come in for this that they're not really there to help themselves, but they're there to help mankind in the future. So now with the newer trials, we've been using this what's called PEC Direct VCO2, where we've been using devices that are perforated, got little holes in them, and this allows blood vessels to come in, but it does mean the patients, like Danielle, have to take anti-rejection drugs in order for the cells to survive. And this has been moving forward, and I'm very excited to say that yesterday Dr. Warnock in the news and his colleagues carried out the very first transplant with this VCO2 product in their first patients in Vancouver. And I see, Dr. Warnock, you're wearing your Alberta country shirt for this particular photograph. But congratulations on the very first transplant here. That's wonderful news, and we're very excited to follow the outcomes. Dr. Kiefer has been absolutely instrumental in developing improved stem cell products that make insulin that can be used in patients. And to cut a very long and complicated story short, he has developed this 7-stage protocol that allow these cells to produce more or less the same amount of insulin as human islets do, and they're able to reverse diabetes in a much more rapid time frame than the previous cells that we've been testing. So we've been very excited about Tim's work and his ability to move that forward from patients to the clinic. And there's various different other approaches that are going to improve the survival of these cells over time. And Dr. Kiefer's group with Jennifer Bruin and Dr. Rosenia showed that this map of how the islet develops inside a patient, inside a normal human pancreas, and then in the Petri dish, how they can develop these same kind of mature cells by adding different hormone factors and other chemical treatments at different time points. And the question now is, what are the best cells to transplant? Is it these ones we're just testing in Edmonton and in Vancouver right now, these stage 4 cells, or should we be transplanting cells that are more like the cells that we put in Danielle that are like human islets that function right away? And the answer is we don't really know. Some data that we were looking at together this afternoon shows that if we look at these stem cells at the stage 4 level, the same ones we're using in these ViaCyte trials, the amount of oxygen these cells need is half of that of a human islet. And that suggests perhaps that when we transplant these under the skin, before they get their new blood supply, maybe more of these cells will survive compared to the more mature cells. We just don't know, we don't have all the answers on that at the present time. But Dr. Kiefer's group, I'm certain, is going to deliver in the end of the day. He wrote this very nice review last year entitled Closing In on Mass Production of Mature Human Beta Cells. And he was also in Kyoto in Japan last year, working on the possibility that we could take patients' own stem cells, turn them into insulin-producing cells, correct a genetic defect inside the cell, and maybe for the first time really robustly cure diabetes. And I see that is absolutely the future and the way ahead. We've come a long, long way with islet transplantation and now with stem cell transplantation. I took you on the road from the very beginnings to Paul E. Lacey's work, and we can really change the future with intense science, focus and passion. And we know that the Edmonton Protocol was just the beginning, and it will be, I'm sure, relegated to the history books sooner rather than later if we can move these next stages forward to the clinic with the stem cells as fast as possible. It's a very, very exciting time, and it's a great privilege to be involved in this area, and I see that for sure an ultimate cure for diabetes is within our grasp. We don't have it right now, but it's certainly within our grasp, and it's going to take intensive effort and collaboration and teamwork in order to get to the point where we have something far better tomorrow than we have today. Finally, I just want to mention the people in my own lab that have done all the work: Andrew Pepper, Anthony Bruni, who just finished his PhD, Boris Gala Lopez, who's just moved to and got a successful job as a transplant surgeon in Halifax, Marius Brauer, who's doing a transplant fellowship right now, and I've been very fortunate to work with many really bright students over the course of the years, as well as a huge clinical team that's been involved with this exciting journey to date. So I'd like to thank you very much, and very happy to answer questions.
Wonderful, James. So we have a few minutes for questions for either Dr. Shapiro or Danielle. Yes.
So thank you very much for the really interesting, and also thank you for a beautiful story. For Dr. Shapiro, I have a question regarding some of the numbers that he was presenting on the cost of diabetes. Because I think that you are sort of adding up the cost of treating type 1 with type 2 diabetes.
Yes. Yeah.
So I was wondering, what are the perspectives of islet transplantation for treating type 2 diabetes?
So the short answer to your very smart question is we have no idea. We think that an islet cell or potentially a stem cell transplant will be as successful in treating some patients with type 2 diabetes as it is with patients like Danielle, but we've never done that yet. There have been some pancreas transplants done, quite a few actually, in patients that have type 2 diabetes. Selected patients has been very successful, suggesting that if we can give the same kind of what we call endocrine transplant, as we can do a whole pancreas transplant with an islet or a stem cell transplant, we'll be able to impact type 2 diabetes. But until we start trials in patients, we really won't know for sure.
Yes, at the back.
Yes, you mentioned how there's not nearly enough to go around for islet transplants. How do you decide who to transplant?
So we have a very rigorous selection process, and it's based on, put very simply, patients that are doing well on insulin and have no difficulties with their control. We say, stay on insulin. There's no reason to consider anti-rejection drugs and a cell transplant treatment and potential risks with that. Why bother? But if someone's having real difficulties in their blood sugar control, as Danielle described so beautifully, dangerous lows, wide swings in blood sugar, impacting secondary complications, and put that together and their quality of life is poor, then we say those patients should be prioritized. And we have objective scores for that. We have what's called a Clark score and a hypo score and a lability index, and we have measures. And if somebody fits those kind of categories, the next thing we do is check the amount of insulin they're taking and the regimen they're on, and how they're giving it, and making sure that their insulin is optimized. So islet transplant is not the beginning. It's seen as sort of fourth line after insulin, intensive optimized insulin, then potentially these continuous glucose monitors and maybe pumps, and then at the end of the line we think about an islet transplant.
Yes, Garth.
Thank you to both speakers for a very inspirational presentation. I wanted to ask both of you questions about this very disabling hypoglycemia. And Danielle, fortunate to be off insulin, but she didn't say too much about what it meant, or whether, even before she did get off insulin, what it meant to get rid of that. And as a follow-up to that, to Dr. Shapiro, do you think that in a more thoughtful understanding of how well these work, we can start to look at other forms of diabetes as eligible for treatment, especially when considering the hypoglycemia.
So the experience of coming off of insulin particularly, it's interesting because as I mentioned, going from pork, synthetics, NPHs, long-actings and short-actings, and then coming to the insulin pump, just Humalog. Through those steps and those journeys, the getting to the Humalog itself was sort of life-changing in each step. The taking away of the long-acting or the cloudy insulin to work with only Humalog was a good feeling. Each step seemed to have a honeymoon phase, but that coming off of the pump and the Humalog altogether, like I mentioned, was a flick of the switch. My body was always hot. I was always fueling the body with sugar and insulin, and it was like a huge fire. And then coming off of it, to be honest, I was cold. It felt normal. It just felt like this huge burden had been lifted. And I thought, oh wow, this is what normal feels like.
What about the lows, though? What about getting rid of the lows?
The lows are scary. The lows towards the end of my diabetes, I would find myself alert and oriented one moment and then down on the ground or lost the next. Definitely scary and uncertain. I'd find myself in situations either stressful or anxiety-ridden, and I didn't quite know what to expect, what would happen. So like I mentioned, I'd bring juice boxes and granola bars and food and insulin, and I'd just be prepared for anything. Now there's just more freedom, less scary. Yeah, those lows, I'd wake up in the morning and there'd be like paramedics standing over me, or my teammates with glucagon injections in their hands, and I just wouldn't know what had happened.
Sorry.
Yeah, that was a terrific talk. I just, as these patients live with their time with the islet transplants, and so they're normal, I guess the question is that do they then get exposed to kind of susceptible to type 2 diabetes, being in the North American climate, where you have, I guess the diet, and so the question is that as these islets lapse in terms of the longevity, is the development of potential insulin resistance living in a North American culture, does that also lead to the fact that they don't, in terms of the longevity of the transplant?
So the question, if I can paraphrase it, is that this fall off in the need for complete freedom from insulin over time, we don't really fully understand in it. Could it be that many of these patients are developing a form of type 2 diabetes? And we think that's probably right. Yeah. And to come back to Dr. Warnock's point about could we maybe broaden the criteria for future patients coming forward for an islet transplant, I would say over the last 20 years, rightly so, we've been very cautious moving forward. And safety has always been our number one goal, not to cause harm. And I think we've shown now with 20 years of experience that this is a very safe procedure, and it can be very effective in some patients. And we know the side effects, there are potential side effects, but overall those side effects are probably, in most patients, a lot less than the risk the patient faces with diabetes, particularly if it's poorly controlled. So could we maybe consider broadening the criteria and treating children? In the early days of kidney transplantation, people would have been horrified at the thought of giving a kidney to a child when dialysis is available, and dialysis is supposedly life-saving, but the quality of life on dialysis is terrible, and even today. So the ability to give a kidney transplant to a child is life-transforming. So in the future, could we do the same thing for a child? I think if we can have a little bit safer anti-rejection drugs, and if we can keep our cells functioning even better in the long term, then we could perhaps open the floodgates a bit more. And by then we won't have enough organ donors, we'll need TIM cells.
I think there was one more question. Yeah, last question. Go ahead.
I'm curious to know about, maybe you like comment on this as well, the differences in the response with the stem cell derived islet dystrophy cells. So you mentioned that when you were using just donated islets, you had to sometimes add multiple batches of islets to patients. Is that due to batch-to-batch variation in production with the donated islets? And if that's the case, do you expect you might have to do the same thing for these ESC-derived cells, or because you have more tightly control their insulin production, you might not have to do more than one transplant?
There's no question that the quality of an islet preparation varies greatly between one donor and the next. We might have a young donor that doesn't give as many islets, but those islets could be very potent. In fact, they could be every single islet that we've got out of the pancreas. That might be enough for that person. In another case, we might give 1 million islets, but they might not be very good islets, and then still the patient doesn't get the maximum benefit that we would hope for. So there's a lot of variability in the human islet preparation. I'm pretty sure, what I know today is that somebody like Danielle, when we put 2 islet preps into her, we're still nowhere near her normal reserve. The pancreas has a lot of normal reserve in it. And I think when we start to get into the realm of stem cell transplants, as long as we can do this safely, we'll be able to keep pouring the cells in until we reach the point that the patient is completely normal and has the reserve that somebody that doesn't have diabetes has. And I think then we'll see much better longevity of the cells. Does that make sense?
Okay, last question. Last one.
I'm confused about the concept of all type 1 diabetics not being the same, not responding the same, and how physicians are diagnosed, ultimately how someone gets to your doorstep. And you just listed the criteria, but it's not clear to me, are all diabetics not equal?
No, no.
So how does one know? Who knows how to handle that?
So the criteria today in Vancouver and in Edmonton and most of the centers that are running islet cell transplants across the globe use the same criteria. And you have to be on a good insulin regimen. Some people do really well. We don't understand why. Why is it that one person who's giving exactly the same amount of insulin day to day has perfect control? Another person that's giving the same amount of insulin as that person, eats the same food, does the same amount of exercise, has a completely terrible control. And if we could understand that better, maybe we could improve the quality of life for all patients with diabetes. We don't know. So no, people are not equal when it comes to that. And we don't know why.
All right, on that note, I would like to thank you both for the wonderful presentations and participation. Danielle, we have some flowers for you. Thank you.
Thank you, Danielle.
Dr. Shapiro is flying back to Edmonton for an early morning back to the lab, so we thought we'd get you something smaller.
Some perfume. Just some stem cells.
Please join me one more time for thanking both of them for watching.
Thank you. Thanks, Danielle. Thank you so much for doing that. It's a beautiful talk.